Everyone, thank you very much for joining our seminar today. Just to check, Olivia, is there anything that you wanted to say before we start?
You can start, Donna. Thank you.
Thanks. So I'm delighted to welcome you to the I Hear Special Interest Group webinar, which is run by the Economics of Children's Health and Wellbeing SIG. And we've got our speaker, Joachim Vidier Martin. I'm really sorry if I've pronounced that incorrectly, but he's going to be talking about starting school and ADHD. When is it time to fly the nest? Joachim is a research fellow at the Centre for Health Service Economics and Organisation at the University of Oxford. And he's got a wide variety of research interests that focus not only in looking at economics of children's health, but also looking at applied microeconometrics, health economics, labour economics, and public health. So I can't wait to hear you talk. Over to you, Joachim.
Yeah, great. Thanks so much for the introduction. Let me share the slides. Can you see my slides now? Yeah, great. Okay, so thanks so much for being here. Thanks for the invitation. So today I'm presenting joint work with Katia Nicodemo, who's at the University of Oxford and Verona, and I think she's in the audience today, and Katia Nicoletti, who's at the University of York. Now in this paper, what we're going to be doing is looking at the relationship between school starting age and ADHD, which is a topic that's been sort of widely explored in the economics literature, and we'll try to advance that literature by looking at a few things, especially at what's the mechanism behind some of the patterns that I'm going to show you. Now, the paper is going to be submitted soon, so if you have any comments or anything you think is wrong, please let us know. And I'm also very happy to take questions along the way if you have so. So if something is unclear, please feel free to interrupt me. Unmute yourself and interrupt me. That's fine for me. So in terms of the paper, like what's the motivation to look at this topic and why school starting age? How did we get here? The first thing we know is that in most countries in the world, school starting age is determined by a cutoff point, right? So for instance, in England, the country that's the base of our study, we know that children born, so September 1st sets the cutoff for school entry, and then children born right before that cutoff point, they're early starters, the other ones are going to be late starters. And that creates differences of almost up to a year within the same school class. Now, there's a belief that's supported by some literature that starting school when you're too young may have a permanent negative effect on cognitive and psychological development of children. And this belief has motivated what is called redshirting, which is that in some places in the world, not in England, which is what I'm looking at today, but it's more common, for instance, in Australia, sometimes parents delay the school entry by a year, basically trying to prevent these negative effects. However, recent evidence has shown that this practice is not really justified because the effect of this negative effect of being an early starter on cognitive and non-cognitive skills decreases rapidly with age and is mainly driven by absolute age at assessment. What do we mean by that? What we mean by that is that if I examine all the kids, let's say at the end of the second school year, some of these kids are younger than some others when they're taking all the tests at the same time. And these differences in age is actually what's behind the difference in cognitive development. Now, in this paper, we relate to this debate about redshirting, and we focus, instead of cognitive skills, we focus on mental well-being. And we're going to take attention deficit and hyperactivity disorder, ADHD, as our main outcome of interest. Now, the first thing I'm going to show you is that early starters have higher rates of ADHD diagnosis and prescriptions in England. And we are in no way the first ones to do that. There's a lot of evidence of all the papers I'm citing here that the same pattern basically shown in the US, in Canada, in Iceland, in the UK, and also in places in Europe, with the only notable exception being the Netherlands, as shown by Dalsgaard and co-authors in 2012 and 2014. Now, points 1 and 2 are kind of straightforward. Many people have done that. The important contribution of our study is that we're going to study the mechanisms explaining the short and long-term effects of school starting age on ADHD. And I'm going to conclude by by sort of discussing which interventions could mitigate this gap. Now, why do we focus on ADHD? Well, we know it's a neurodevelopmental disorder that's characterized by kids being overly active, impulsive, and having difficulty in concentrating. We know that ADHD has consequences on educational and economic outcomes, which is basically why we look at this from an economic background. And we also know that ADHD is primarily associated with genetic factors. I'm going to dive more into this later. Before I explain to you what exactly we do, I want to show some motivating evidence of this pattern I've been mentioning so far of early late starters and ADHD rates. So in England, let me define children born in July and August of a given year as early starters. So these are the kids that are going to start school when they're a bit younger, and children born in September and October as late starters. So in red and blue for you to see it. Now here I'm plotting on the horizontal axis, I'm plotting ages from 0 to 15, which is the data we're going to have. And on the vertical axis, I'm measuring the percentage of children who at a given age had at least one ADHD prescription in the records we use. As you see, after 5, sort of the percentage of kids receiving at least one prescription starts deferring, and this gap widens over time. So this is interesting for 2 reasons. One, it's what we find in other places. 2, unlike other outcomes, this gap doesn't seem to vanish over time. And we're going to try to see what's behind that. I can also present this to you in another way. So I could take the September 1st cutoff point for entry of school, and I could plot the average by week of birth. So I could go 1 week after, 2 weeks after, 3 weeks after, if you see my mouse, and the same for those born before the cutoff point. And as you see, those that are born before the cutoff point, that is early starters, the ones at the left of the dashed line, have much higher rates of prescriptions than the ones on the right. Now, the first contribution of this paper is, as I said, so far, this is what we already know. Now, first thing we're going to do is try to explain why early starters have higher rates of ADHD. And there is sort of a vast literature that attributes this gap exclusively to the fact that these kids are younger relative to their peers. And basically, this arises from sort of peer comparison biases. What we're going to do is we're going to present a framework that considers more mechanisms than that. And then I'm going to sort of dive through the maths that lead to that, and eventually show you which is the mechanism that drives this. We're going to be considering 4 of these mechanisms. And again, I'm going to go into this in more detail, but essentially the different papers in the literature have mentioned these mechanisms. No one has considered them all at once. These 4 mechanisms are, number 1, the length of school exposure. So at a given age, so if we keep like age constant, let's say we measure kids the moment they turn 7, early starters have been more in primary school and less in preschool. So they've had a longer exposure to school. Number 2 is the age at entry, the fact that kids who enter at a younger age may be more immature, which may lead to stress. Third is this relative age mechanism I was discussing before, which is picked up by peer comparison biases in either teachers or GPs' assessments of ADHD, but can also induce stress in kids. And fourth is the absolute age at test. That's the fact I was mentioning before, that if we measure all the kids in a class today, we are effectively measuring them at different stages of development. And I'm going to go back to these 4 mechanisms in a bit. The second contribution is that we're going to try to see why the effect of school starting age on ADHD does not vanish with age. Because we know that that's what happens with most cognitive and non-cognitive skills, but the figure I showed you earlier shows that there's sort of some persistence or even some increase in this pattern. Now, in terms of outline for this presentation, I'm going to spend a bit of time on the conceptual framework, because that's what drives the rest of the analysis. That's the part of the talk that's a bit more tedious. After that, it's all sort of fairly straightforward econometrics. Then I'm going to say a couple of things about the institutional background in England for those that do not know the system. I'm going to quickly review some of the features of our data and our empirical strategy. And then I'm going to present 3 sets of results if I have time. Otherwise, I'll keep it a bit shorter before moving to the discussion. So in terms of conceptual framework, this is sort of like the big part of the paper is what we do here. And then when we look at the sort of mechanisms that drive ADHD, we know first that it's highly heritable, but that differences in environment, even between identical teams. So we sort of did a bit of literature review when it comes to twin studies, and the severity of ADHD symptoms can be sort of modulated by the environment the kids are exposed to. And then in school, the fact that there might be differences between early and late schoolers may generate some stress that in turn leads to an amplification of ADHD symptoms. And then another of the factors that's very much mentioned in the literature is this peer comparison bias I was mentioning, right? So the fact that teachers see the kids all at the same time in the same class, they do not take into account the fact that they have different symptoms, different development, because some of them are a bit older than some others, and then they perceive the symptoms of those that are younger as worse than they are. And then this relative immaturity can also worsen the kids' mental health. And there's also evidence of important factors like being less developed from a social emotional point of view, leading to increased bullying, which in turn leads to increased stress. Now, all of this can be picked up by the 4 following mechanisms. The first one, as I said before, is the length of school exposure, and it's the fact that if we observe them at the same age, that is when they turn exactly 7 or just 8, some of them have been exposed to school a bit longer than some others. Mechanism number 2 is the age at entry. Mechanism number 3 is the relative age, these peer comparison effects I was alluding to. And mechanism number 4 is the absolute age at time of test or diagnosis. Now, mathematically, we're gonna think about this the following way. So the diagnosis or prescription of ADHD at a given point in time t for kid I depends on the time, because we know ADHD becomes more prevalent as kids grow older, and the fact of being an early starter plus some idiosyncratic error term. And then we're gonna allow this effect of early starter, so this gamma t, to depend on the 4 factors I was mentioning before. And this very much follows the work by Cornelissen and Dusman in Journal of Political Economy. This is gonna depend on the length of school exposure, on the age at entry, on the relative age, and on absolute age. So we're gonna assume that there's this linear dependence. It can vary over time, so we're not keeping it fixed over time. Like every time you might have different coefficients, but they do not interact with each other. That's a basic assumption of our paper. Now, if I keep this equation here, I compare early and late starters, when there's only one entry point of school, comparing early and late starters is equivalent to increasing exposure by a year, because for the same age, an early starter would have spent almost a full year more in school. And then I would be decreasing age at entry, the relative age, and the absolute age at test by a year if I'm looking at an early starter compared to a late starter. Now, it's easy to see that then the effect gamma t is driven by positive gamma x and then a negative on each of the rest, right? Like that's basically what the increasing is the positive, decreasing is the 3 negatives. And then the problem becomes that when I try to identify the single components of each of these 4 mechanisms, I cannot, because they all move at the same time. They either all increase by 1 unit or decrease by 1 unit when I compare an early to a late starter. And that's sort of the problem of multicollinearity. Now, what I can do is, in the spirit of Crawford and others, is I can observe the early and late starters in the same school year. So let's say the first day that they start 3rd grade. If I do that, then the length of school exposure is the same, because they've all been there only for 2 grades before that. And then I get rid of the first coefficient here. I'm only left with 3 others. I'm going to call that the same grade effect. That's why there's a gamma G here, because I'm observing them at the same school year, right? That's equation 4. And similarly, what I could do is I'm going to assess the symptoms of these kids at the same age, the moment they turn 8 years, let's say. I could call this gamma A for gamma H, and I would be keeping age at test, so the absolute age, constant. So I would be getting rid of this later term. And I'm going to call this gamma A the same age effect. Now, as you can imagine, I'm doing this for a reason. So I've got like the same age and the same grade effects. What I can do now is take the difference between these two, and then I'm only left, out of the 4 coefficients, I'm only left with 2. And what I'm going to show you empirically is that the sum of these two goes to 0 from grade 4 onwards. This is then a sign that it must be the other two. I'm going to interpret that as a sign that it's the other two mechanisms that actually drive the effect. And that's the relative age, which is what a lot of the economics literature is talking about, and the increased stress from starting at a younger age at entry. And I'm going to leverage the fact that I also have information on anxiety to basically rule this one out. And then I can credibly claim that the relative age that many others have provided evidence for is actually what drives this effect. Now, let me move to the institutional background very quickly. So in England, children start reception class. That's equivalent to US kindergarten at the age of 4, and they start primary school at the age of 5, or on the year they turn 5. The attendance to reception class is close to universal. So Cornelius and Dossman, with a cohort of kids born in 2005 and 6, show that it's 96%, I believe, of the kids that attended reception class. And almost every class is enrolled in the correct academic year, or in other words, there's no redshirting in England. The schools have converged to a single entry date. There were more before. Now, basically, the cutoff point is in every school is September the 1st, and we do some robustness tests to show that that's okay. And then I'm gonna define children born in July and August as early starters, and they are gonna be entering their class almost a year earlier than those that are born in September and October, which I'm gonna call late starters, same as I did before. Now, about ADHD. As I was saying before, this is sort of a very common, or like one of the most common neurodevelopmental disorders in childhood. It's characterized by impulsiveness, hyperactivity, difficulty in concentrating and in attention. Very importantly, to be diagnosed with ADHD in England, kids should display continuous symptoms in at least 2 settings. So it's not enough that the kid has difficulty concentrating at home. It should be at home and in another environment. And the 2 environments kids spend most of their time at is school and environment. That's why the assessment of teachers of their symptoms is actually crucial in the diagnosis of ADHD. And teacher reports are a big part of that. Now, treatment for ADHD only starts after the age of 5 on the drug side, and it's usually a combination of behavioral therapy and drugs. In terms of data, we're going to be using data from Q Research, which is a database of primary care records. They've got information on over 35 million patients from almost 2,000 practices in England, and that's matched with hospital administrative data. Now, we get individual patient data with a mother-baby link, and the outcomes we have like the prescription data from GPs, some demographic characteristics, and some SES data at the postal code level, which I'm not really going to show you today much about. Now, the sample we got, so we don't have like these 35 million patients, we get a subsample of those, which are singletons that were born between 2002 and 2010. We're going to restrict this to those kids that were born between July 1st and October 30th, because I'm trying to keep them sort of fairly similar in the spirit of a regression discontinuity design. And that leads to a sample of just below 100,000 children. So this is a sample we're going to be working with. And then there's 2 important definitions. One is ADHD, which we're going to be measuring at the extensive margin only. So I'm going to take ADHD as 1 if that child received at least 1 prescription in a given age or a given grade, and 0 otherwise. So I'm not looking at the intensive margin. I'm not looking at how many drugs they have or how intense they are or how many times the amount of the minimum effective dose they're getting. I'm just looking at, do they have 1 or not? And then the other indicator I'm defining is whether kids is an early starter or not. So if they were born between July 1st and August 31st, they're early starters. If they're born in September in October, then they start with the next cohort, and therefore they're late starters. They're going to be a bit older when they start. In terms of empirical strategy, we're going to keep it very simple. Then we do like a bunch of other models that probably I don't have time to show. So for every period T, that's going to be for every age and for every grade, I'm going to define ADHD as a function, as a linear combination of like a time dummy, the fact of being early starter, a bunch of individual and household characteristics, general practice fixed effects, which means that effectively we're comparing within general practices, a year of birth fixed effect. So I'm only been comparing kids from the same practice and the same year of birth and the error term. As I said, ADHD is going to take value 1 if they receive a prescription. J denotes the general practice, and S denotes year of birth, and these are the two fixed effects I was discussing. Early takes value 1 if the kid is an early starter. As I said before, we exploit within GP practice variation by including these GP fixed effects. Those characteristics are fairly balanced, as you can see here. So for all sort of socio-demographic characteristics, we find there's no differences within practices. And we also control for sex, ethnicity, postal code, and maternal age at birth. Now, because the prevalence of ADHD increases with time, this estimate that I was showing you before, so this estimate gamma gives us percentage points. That's going to be hard to interpret because like 0.1 percentage point may be very large at a very young age when no one is being diagnosed and mean a lot less further in time. So we're going to rescale that and present everything in terms of percentage increase. Okay, so let's dive into the results. Still have some time, and I've got hopefully three sets of results I want to present today. The main result we have is what's the gap in the ADHD prevalence rates by age and by school grade. And this is very, very similar to what others have done. So what I'm showing you here is horizontal axis, every age from 5 to 15. And then every dot and confidence interval is a separate regression. So what I'm showing is the first one here is the result of the equation I'm showing here, equation 7, for kids age 5. Second dot is for kids age 6, and that all the way down to 15. And the point estimate, so this, let's say 0.4 we end up with, that means that early starters have 40%, are 40% more likely to receive a prescription for ADHD, conditional on all the fixed effects and individual characteristics I mentioned before. Now, these magnitude sizes are very large because they stabilize around 50-something% after age 9. They are in between the estimates we find for other countries. So Elder Lubotsky come up with something around 30% if we compare it to the same sort of relative sort of increase relative to late starters. Some others go up to 60-something% around ages 8 or 9. So we're sort of in between these estimates when we look at England. Now, this is sort of nice to see, but there's no novelty here. We already knew that that was the case. What we now try to do is we use the framework I presented at the beginning to explore the mechanisms behind this finding. And I told you that for that, I needed to compute the same age and the same grade estimates. And this is what we do here. So recall we had this gamma decomposed in 4 factors. And that when I was taking the difference between the same age and the same grade effects, everything then is driven by either the length of school exposure or the absolute age at entry. What we see here is that after grade 9, these differences between the blue and the red coefficients are almost indistinguishable from each other. So the blue ones are the same as I was showing you before, same exact figure. The red ones are the estimates when I compare kids for the same grade. So for reception class for grade 1 and grade 2, all the way down to grade 10. And then we can also basically test these differences. When I say that these are not significant, you have that here. That's the exact same table, but we're showing it numerically here. Now, these findings, which is sort of the key finding of the paper, what it shows is that the effect of length of school exposure and the effect of absolute age is going to tend to zero from grade 3 onward, so after grade 4. Now, absolute age, the effect of absolute age is expected to be positive because the rate of ADHD prescriptions increases with age. We know that from basically every country in the world. And the effect of length of school exposure is also positive because if we condition on the same age, there's higher stress for late starters because they're in a higher grade. So under these expectations, the fact that this sum of these two is 0 also implies that both of these tend to 0 after age 8. And then the effect of being an early starter is driven by relative age, which is what many others have said, and the age at school entry. Now, the issue is this all a peer comparison bias, or is this also stress? Like, this is sort of basically where we end with this mathematical exercise. And why is this important? It is important because it's not only like a nice bunch of equations that look good on a paper, it's because the interventions that we can propose to mitigate these gaps depend on whether it's a peer comparison bias that teachers are suffering from, or the fact that these kids are exposed to higher stress. You may imagine that one involves, like, the solution for one of these two problems involves training teachers differently. The solution to stress maybe involves going back to multiple entry points throughout the school year. Now, I think our reading of the literature is that a lot of other papers cannot say much about this, cannot fully rule out one of the two. And that's because stress is very hard to measure. Unless you've got like data on cortisol levels of kids or so, which we only usually have for a very small sample, it's hard to measure. Now, what we're going to do is use the fact that the Q Research database I was mentioning before has data on anxiety diagnosis and prescriptions. And then we know that anxiety disorders, we can see them as an extreme, among other things, sort of an extreme manifestation of stress, right? So the next thing we're going to do is we're going to replicate the previous figure, that's figure 4 here, with anxiety prescriptions. And what we're going to find is that the effects are basically very close, much closer to 0 after the relevant ages, and also not different from each other. And if we do the same with diagnosis, same picture prevails. So the 0 line, which is what I'm sort of moving now with my mouse, contains most of the estimates. So we see that the effects for prescriptions are smaller for anxiety than they are for ADHD. For diagnosis, the results are very close to 0. And we interpret that as evidence that stress is not the driver of short or long-term effects of being an early starter in ADHD. And therefore, the relative age comparison is likely the explanation for the long-term ADHD gap between early and late starters. And there's sort of further support of that in the literature. So in that sense, we agree with what many others are saying. We just show like a more comprehensive framework taking into account other mechanisms too. Now, the second contribution of our paper, and I still have some time to discuss this, is trying to see when do these gaps initiate and why does the gap not vanish? And sort of the answer here is the fact that ADHD prescriptions are very persistent. So for ages 9 to 15, that's column 1, if I look at the unconditional prevalence of ADHD prescriptions, that's very low, right? That's around at most 1.2%. However, if I measure the prevalence for those that had the drug from ages 5 to 8, that's much, much larger. And this sort of adherence or this to medication or this persistence in prescriptions is sort of one of the drivers of the results we find. Because when we look, so I'm trying to replicate the main figure now only with first-time prescriptions. So I'm not considering whether you received a prescription or not, only if it's the first time that you receive one, the effects become close to 0. So all the gaps we were observing after age 8, 9 in the previous figure are essentially driven by these prescriptions here, by the ones that were written when the kid was between ages 5 and 8. And I think that's one of the other contributions we have to the literature. This is sort of a summary of what I just said. So we see no effect of being an early starter on first-time prescriptions after age 9. The effects up to age 8 are very similar in magnitude to the ones we had before. And from that, we can conclude that the difference in ADHD prescription between early and late starters is explained by the persistence of treatments that were initiating at a young age. And that, combined with the fact that the relative age is the main driver of these differences, sort of points towards the fact that an adequate diagnosis in these early years is sort of the key to reduce these differences in treatment. Now, I still have some time to get into sort of reconciling the literature of what I just saw with the literature on marginal diagnosis. And there's no results I'm presenting you here. I'm only discussing what others have done. But we're trying to see sort of how to reconcile this with other papers, right? The first thing is that, as I said before, ADHD diagnosis involves examination of the kid and then interviews with them, the parents, and the teacher, or some sort of teacher reports. And then there is from Elder, from Forster in in Canada, there is evidence that teachers drive this gap, so that the teacher's perception of kids within the same class are driving ADHD gaps. And it's not parents looking for a differential diagnosis between early and late starters. That, combined with the fact that we find that the peer comparison effect is sort of the main driver of the effects, sort of leads us to see that teachers are either overestimating the symptoms in early starters or underestimating the symptoms in late starters. And sort of the perceived symptoms, basically they're shifting the distribution to the right for early starters. That's what Pearson and co-authors discussed in 2021. And this is sort of the graphical representation of that. So we have for early starters and for late starters in blue, we have sort of the same actual distribution of symptoms. But because early starters are a bit younger and a bit less developed, sort of there's a rightward shift, or for the graph below, a leftward shift on the perceived distribution of symptoms. Then because this diagnostic threshold is unknown to the teachers, what ends up happening is that they evaluate them differently for early starters and late starters. And that's this idea of sort of who is the marginal diagnosis being affected by these comparisons. And then the key question here, and we cannot say much, and I may skip that just to leave more time for discussion, is that if we had a scientifically correct diagnostic threshold, then it would be easy for us to tell if the effects we find are due to an overdiagnosis of early starters or an underdiagnosis for late starters. Now, of course, the main caveat of that is that this sort of scientifically correct threshold is unknown. What we try to do in the paper to contribute to this debate is make some inferences for certain subgroups who are at a higher risk of under or overdiagnosis. For instance, we look at girls in the paper because we know that girls tend to be underdiagnosed. The reason for that is that their symptoms have more to do with inattentiveness and not so much with impulsivity. So they just seem, they move less in the class, to make it very, very simple. We also do that for high and low SES. But basically we don't find much. So the fact that we don't know what the threshold is and that the results here by sex and by socioeconomic status are pretty imprecise sort of makes us interpret this with a lot of caution. And I'm not going to dive into this to leave some more time for discussion. Now, the results I presented today come from a very simple empirical specification. If we use a regression discontinuity design, the results are even larger. So the magnitudes are very similar, but slightly larger than the ones I presented. if you wanted me to include family fixed effects, so effectively compare siblings within the same family instead of children within the same general practice, the results are fairly similar to the ones I presented, a bit more imprecise. We could also estimate nonlinear models. Results, again, kind of fairly similar, a lot less precise at age 5. If we use GP diagnosis instead of prescriptions, the results are very, very similar. Oh, this doesn't work. To the baseline set of results. And if you are worried about sort of measurement error in the date of birth, and you would like us to exclude sort of kids that are born too close to the threshold, the results are, again, very, very similar to the baseline results. So I had 45 minutes, so let me spend the last 5 on the discussion of paper and the key takeaways. I think we take away 3 things from the set of results, and that leads to a few policy implications. The first one is that, as we knew, starting school early leads to an increase in ADHD prescriptions. Now, this is mainly explained by a relative age effect, which many others have said. But the contribution of the paper is that the stress channel, which some had suggested but not really looked into, we can rule it out because we have this information on anxiety diagnosis and prescriptions. And we conclude from that that this peer comparison bias is the main driver in the gap in ADHD prescriptions and diagnosis between early and late starters. The second takeaway is that the long-term effects of school starting age on ADHD after the age of 9 are driven by the persistence of prescriptions that occurred between ages 5 to 8. And that's what sort of helps us reconcile why do the effects on cognitive skills vanish after ages 9 and 10, but the prescriptions for ADHD don't. The third takeaway, and I'm not sure that's really a takeaway, is that, of course, a key issue here is whether we're over-prescribing early starters or under-prescribing late starters. And because we don't have much precision, and because in that framework of the marginal diagnosis, the correct threshold is unknown, we do not add much to that debate other than the heterogeneity analysis I was showing you. In terms of policy, the first implication of our study is that the practice of redshirting, which we are observing in other countries, cannot be indiscriminately applied to all children. And then for girls, for instance, that could increase the risk of underdiagnosis in the event that that's what's happening. Now, better strategies that we propose in the paper is, one, sorting children into separate classes that ensures that they have children of similar ages, at least when they're very young, because that's a critical period for diagnosis. And then there's also one from, let's say, the supply side, which is that maybe we should improve the way we diagnose and refer to specialists between ages 5 and 8, taking into account that these biases play a crucial role and then sort of perpetuate these differences in prescriptions. How would we do that? One would be training teachers who are having shown to sort of drive these differences in diagnosis. Or another way to do that is to give less weight to the teacher's reports when the kid is a very early or a very late starter. All of these sort of have been proposed in different papers looking at different strategies. And I think that is the conclusion to my presentation. There's still some time for discussion or for me to go through some of the appendices if you would like me to.
Thank you, Joachim. That was really interesting. Does anybody have any questions that they'd like to ask? You can either put your hand up, or if you want to write in the chat, that would be really interesting. Hanifa, if you'd like to ask your question, I think you've raised your hand first.
Yeah, thank you so much. It was really interesting. I may have missed this part, but I was wondering if like there is any difference in the performance of these two groups, because if like in school performance, I mean, like if there is no performance, I'm wondering on what basis they are comparing with other peers. And I also have another question, whether you think that you have any evidence of birth timing manipulation around the cutoff by the parents. So maybe it's worth to check family background around the cutoff to see if they are similar.
Yeah, thanks, Hanifa, for the questions. So on performance, not in our paper, but we have sort of vast evidence that everything that comes to sort of skill tests that they do around, let's say, this critical period we were referring to, there's sort of large differences between these two groups. And that's part of what the teachers are capturing. Like some teachers seem a bit more, or some kids seem a bit more skilled. The problem with ADHD is that they seem more skilled and they seem to be paying less attention or more attention, but this only seems to be driven by the relative comparison of the two. Then when it comes to the question you were referring on birth timing manipulation, so we do a bunch of things in the paper. One is sort of exclude the ones that are very close to the cutoff point. The other is measuring the density, whether there's sort of jumps in the distribution of births around September 1st cutoff point. And all the tests we run sort of reject large differences. One thing you mentioned that we don't do and we could do is sort of do that by groups. So we're doing that, like pulling everyone. If I understood your question correctly, you may be more worried about certain subgroups being the ones that manipulate threshold.
Yeah, I was wondering if, like, for example, more educated parents are more prone to like manipulate this birth timing while others don't care that much.
Yeah, so that would show, well, partly would show kind of here on socioeconomic status. So we're defining these top two groups as high, as low as yes, these bottom two groups as high as yes. I mean, there's a negative coefficient here and a positive coefficient here, but they're similarly deprived. So in a way, those cancel out. When it comes to maternal age, the effects are also very, very small. When I look at maternal age in a continuous way, the effects are also very, very small. These are all effect sizes, so these are all relative to the mean. So yeah, we don't find large differences. It's true that we don't have a lot. Like we don't have parental education, we don't have family structure. We don't really have a good measure of the number of kids in the household because we can see siblings that are born in our 2002 to 2010 data frame, but we don't know if there's earlier or later siblings. So family size is not something that we really exploit because we don't have a good measure of it. And then the ethnicity, we only have ethnicity, so we don't have things like I don't know, more detailed classifications or nationalities or so. But at least with the things we have, like it doesn't seem to be the case that there's manipulation around the threshold. And that's also supported by the fact that you could think about manipulation in the registration of births. So that's for sure one issue. But if you're thinking more about like certain types of parents bending the rules, evidence from other papers shows that I think it's 90-something% of a very close to 100% of the kids are in the right school year. So they don't seem to have been born in the one group, but then parents manage to push them into the other.
Nicolau, if you want to unmute yourself and ask the question.
Yes. Hello, can you hear me?
Yeah. Hi, Nico.
Thanks so much, Joaquin, for the presentation. Very nice. I had like a similar question throughout the presentation. I was also thinking about this kind of selection into treatment because I know, for instance, in countries where you can kind of delay your entrance to school, there's a big selection of high CS parents being aware of kind of your presentation and trying to delay their children's entrance to school. So I was kind of thinking a similar manner. If actually parents kind of plan the date they're having their kids. So I think probably with your family fixed effects, this would I was kind of convinced like that this is not the case, so that's not the driver of your results, because I guess your family fixed effects would rule this out. But yeah, that was like my first point, similar to previous comment. Second, in the last years, like there's been like all this literature, no, showing that ADHD, no, had like a lots of overdiagnosis, no, in early 2000s, and I guess like the number of diagnoses has decreased massively over time. I was kind of thinking about kind of cohort effects. If you could see like these kind of differences over kind of different cohorts, how they kind of decrease.
Yeah, thanks, Nico. That's actually great because I skipped that. Now I get to show it. Okay, so first thing, the family fixed effects you were alluding to, the effects are fairly similar to the ones I showed you before. I have to increase the bandwidth, so there's a bit of a trick here because if you keep it at 60 days, then you need families with 2 kids and 1 on each side. It gets very small, so I then go a bit further. Instead of 2 months on each side, I think we do 3. But then the effects get very, very similar. That's number one.
Just to clarify, like I guess this comparison would be within a family, a kid who's born, a kid who's an early starter and a kid who's a late starter.
Exactly.
That's basically
yeah.
So
So within one family, there's at least we restricted to those with at least 2 siblings, and from those restricted to those that have 1 early and 1 late starter.
Yeah. So I think that's very convincing.
Yeah. And then, so across cohorts, we were thinking, well, partly on what you're doing on this sort of evolution of trends over time in prescriptions, and then partly on the fact that we start with kids that were born in 2002, and then there was an evolution in England or this convergence to a single entry point. And then we were worried, what if there's issues with that? Like, what if these cohorts are very different from each other because some early starters are actually not that older than the late starters? So what we show is first, in terms of trends, prescriptions over time are larger for those born in 2008 to 2010 compared to those born in 2002 to 2004. Okay, so sort of the older kids, the younger kids, the kids that are born a bit later in our sample tend to have more prescriptions, of course, because they're born in 2010 and our data finishes in 2020 or 2021. I cannot draw the blue line until the very end because we don't have enough of that. And then the second point, which is addresses your final comment, is what are the effect sizes by these 3 cohorts? They're kind of fairly similar. They're maybe a bit, over time, they seem a bit smaller for the 2002, 2010. Point estimates, are a bit smaller, but it's hard to tell because then at some point the pattern is almost reversed. There's also a bit of a U shape in many of the estimates. If you take the point estimates at face value, it's not like there are increasing or decreasing trends, right? Like sometimes sort of the blue is the highest, and then if you look at age 7, the blue is the lowest. I'm keeping it ages 5 to 10 here only because these are the ones that I can compare for all 3 cohorts.
Yeah, it looks super similar, like only in the age, if not like it looked something by the just noise. I think it's just more noisy estimates.
Yeah, I think it's more noise than anything. And then, of course, if we try to deaggregate the cohorts even more in more groups, then it becomes even noisier. And then if you pull them in only 2 groups, then you are worried that maybe these are too large of groups. But yeah, like there didn't seem to be much across cohorts, which would have been helpful for us to inform maybe a bit on this debate of over and under diagnosis. Yeah, thanks.
Thanks, Nicolau. Xiao, sorry if I've pronounced your name incorrectly. Would you like to unmute yourself?
Hi, Joachim. It's very impressive presentation. So I kind of like very naive in terms of about economics part of for the analysis of economics part. But could you move back to the framework you were proposing? That if I understand this correctly, you have like you try to analyze it by taking the absolute value of the age, absolute age for the kid, and also the difference between the relative age.
Yeah, so okay, let me go through this again. There's these 4 mechanisms I discussed, right? And these are all continuous things that evolve over time. So length of school exposure at some grade is going to be, let's say, 2 years, and then a bit later is going to be 3 years. The age at entry is something that's fixed over time because you always entered at the same age. You entered at either age 4 or age 5. The relative age compares yours to the others, and the absolute age at test also moves over time, depending on whether I'm assessing symptoms at age 7, 8, 9, 10, down to 15.
Yeah, my worry is like because they are all about age, right? So somehow you can like kind of like this multicollinearity you mentioned is kind of unavoidable. And when you like promote this framework, like the estimates, particularly for the confidence interval, might be like less precise if this kind of problem exists in your regression model.
So we think about this a bit differently. So let's say we're here, and then if I wanted to straight away identify the 4 effects, I can't because they're perfectly collinear, right? So I would be like, if I simply wanted to run one regression and arrive to this conclusion, I can't do this. Now, the way we think about this is by coming to, similar to what Crawford et al. Do, I can fix grade, and then I would keep exposure constant because you would be exposed to the same amount of school years. And that's the same grade effect. I'm still left with 3. I cannot identify anything. Like they're still perfectly collinear. So I'm not claiming that this solves the problem. I'm now left with 3 factors instead of 4, but it's still like the same problem. Similarly, I can take same age and I'm still left with 3, but 1, let's say 2 of these are the same, 1 is different. And it's only when I arrive to the difference that I'm left with 2. Again, I cannot say anything because these 2 are perfectly collinear. The only thing I can say is I rule 1 out when I look at anxiety. So the whole paper is you start for same grade, same age estimates, you take the difference, and the difference leaves you with these 2 mechanisms. And we believe this is where the previous literature got stuck, in the sense that they provided evidence that maybe it was something else, but they couldn't separate 2 effects. Because these 2 are 0, it must be the other 2 that are driving it. And then I learn it's from these other 2, the age at entry and the relative age. I rule out the age at entry, so the stress channel, I rule it out through prescriptions. It's never through the same, let's say through the first analysis. It's only through prescriptions on anxiety that I say, well, it's not stress because anxiety estimates are close to 0. So it must be relative age, which is what many others have said. But we believe this kind of proves it.
Can
So
I understand this as like you actually combine this kind of like some of the covariance for the ages, like so, but you interpret their coefficients differently.
The way I see it is I estimate some effect, gamma, and then I show that gamma must be driven by one of these 2 things. Very much as in any econ paper where you have a main effect and then you have drivers of it.
All right.
And then I use anxiety to rule out the stress channel. Now, you could say anxiety is not the same as stress, sure. And anxiety prescriptions and diagnosis are actually 2 different things. If anything, diagnosis only should pick up like the softest of the 2. But that's as close as we get, us being left with the one mechanism everyone talks about, but at least, so it's not like we are doing any kind of decomposition in a way, like we're coming up with one full effect that's explained by 2 other factors. So we know it's these 2 because the other 2 are equal to 0 when we take the difference. And then we're not doing a straight decomposition. We're just showing, well, stress cannot be much of this effect because like there's no effects on anxiety. But we're not claiming that, let's say, from this framework, you can directly decompose the main effect into other effects, if that's the question.
Sure, thank you.
Thanks so much.
Thank you. I think we may have time for one more question if anybody wants to answer. I think we're just at the end of the time. Stavros?
Thanks, Joachim. Really great presentation. I was just thinking about the stress channel and ruling out the stress channel by looking at effects on anxiety. Had you considered any other longer term consequences of stress, for example, on depression or eating disorders or other types of other potential consequences of stress, just to rule out that channel?
Yeah, that's a good point. I think we tried it with depression and we tried with eating disorders. Eating disorders is not recorded greatly. So I think we didn't find effects, but just the prevalence doesn't seem to match what everyone else is reporting. And on depression, especially for young kids, just no one gets, very few of these kids are getting antidepressants at this age. And anxiety medications are not very common either, but at least a bit more. So we thought about this as from all the potential sort of consequences of stress, let's pick the one that seems the most common. It's true that we could add because we've got depression, anxiety. I think we've got something with self-harm and eating disorders. Eating disorders very poorly recorded. I think the same for self-harm, but we could definitely show depression as well to build on that. Thanks so much. And the analysis is very straightforward because it's the exact same thing and it's already. Yeah, take note of that. Thanks.
Oh, well, thanks everyone. I think we're out of time now, but thanks for a fantastic seminar, Joachim, and thanks everybody for your questions. It's very much appreciated.
Yeah, thanks.
Thank you.
Thank you for all the questions, everyone.
Yeah. Thanks, Joachim.